Today, I'm going to present a case study about hemolytic disease of the fetus and newborn due to anti-cal. Case study is about hemolytic disease of fetus and newborn with an anti-K type. The patient is a 20-year-old woman, G1P0 at her first prenatal visit. She is A positive and had received several transfusions for a total of 5 units of blood 15 months previously. The anti-K was identified in her plasma through an AB antibiotics identification panel, and she is K negative. So the possible outcomes from this pregnancy and the questions that we should ask are: is the fetus in risk for hemolytic disease of the newborn and fetus? How do we know if that is actually a possibility? And also, how should we monitor this pregnancy if this condition is present? To answer these questions, we must talk a little bit about HDFN. As we know, the hemolytic disease of fetus and newborn is the destruction of fetus RBCs by the mother's antibodies. The mother, in this case, was exposed to these antibodies via the blood transfusion that she had 15 months ago. In order for the mother to produce anti-K, she must be K negative, which was confirmed in the blood tests. Her IgG antibodies will cross the placenta and will attack the RBC precursors from the baby, causing anemia, destruction, and suppression of the baby's health. Anti-K hemolytic disease of the fetus and newborn is the third most common cause of hemolytic disease after Rh and ABO. It may cause severe fetal anemia that can lead to cardiac failure and hydrops fetalis. The monitoring is done by ultrasounds of the middle cerebral artery, MCAPSV, which is a non-invasive Doppler measurement of peak systolic velocity. The MCV-PCA of 1.29 to 1.5 multiples of mean MOM is an indicative of mild anemia, and values greater than 1.5 indicate moderate to severe anemia that may need intervention. To confirm that the baby possesses the antigen that the mother lacks and the possible patterns of inheritance, a simple Punnett square with the mom's and dad's possible alleles are done. We already know that the mother is homozygous little k, and the father can be negative homozygous little k, like in the figure 1. So in this case, the baby has 100% chance of also being little k, therefore not inheriting the big K antigen, and not at risk for HDFN. The second scenario, the father is homozygous for big K, and the mom, of course, is little k, so all offspring would be heterozygous, big K, little k, and at risk for HDFN. On figure 3, we see a heterozygous father with big K, little k, and the mom is little k, so therefore the baby would have a 50% chance of being at risk. To confirm the dad's alleles, a blood sample from the father was collected for zygosity testing, confirming the third scenario, in which the father was heterozygous for BK antigen. So at 12 weeks of gestation, the fetal DNA was isolated from mom's plasma to determine the baby's genotype. The fetus was then confirmed to be K positive and at risk for HDFN. To monitor the fetus and the mother's condition, several exams and tests were performed during the gestation. The mother's titer is considered critical when it reaches 8 or more. However, titers does not necessarily correlate with the degree of anemia. So a fetal MCA-PSV must be measured to investigate the anemia in the fetus related to maternal K alloimmunization. At 18 weeks, the MCV-PCA in this case was 1.27, showing that the fetus was developing normally. At 28 weeks, the mother's titer increased to 132, which indicates that the mom's body had started producing antibodies, and the baby MCV-PCA also increased to 1.33 mOM, indicating mild anemia. Then, at 32 weeks, the MCV-PCA increased to 1.65 mOM, and the hemoglobin was 6.2 grams per deciliter. The DAT was positive, and the anti-K was present in the elevate. So the baby needed an intrauterine transfusion at 32 weeks of gestation, and this IUT was performed again at 34 and 36 weeks of gestation. The baby was then delivered at 37 weeks, and he showed anemia and other problems related to HDFN. So it was required several neonatal transfusions, and the baby stayed in the hospital for 3 weeks until her or his levels were better. Another possible treatment for hemolytic disease of fetus and newborn after birth include phototherapy to conjugate the bilirubin level and lessen the need for transfusion, and also intravenous immune globulin.